wanted to start on time. And I think we can get started. So good afternoon, everybody. Magandang hapon sa inyong lahat sa ating mga tagapakinig sa Pilipinas. Magandang gabi sa inyong lahat. So welcome to our first Equity Forum presented to you by the Philippine Nurses Association of America, the Eastern Region. Today, we have our first topic, which is highly relevant to all of us. The topic addressing disparities in diabetes and cardiovascular conditions. So my name is Dr. Worley Remigio. I'm the current Vice President of the Philippine Nurses Association of America Eastern Region and the immediate past President of PNAA New York. I would like to recognize and present to you the co-organizers of this Health Equity Forum. We have the Circle of Presidents representative, the President of PNAA Virginia, Ms. Catherine Peller. You want to say wave, Catherine?
Hey.
We also have the President of PNAA Metro DC. We have Ms. Carol Robles.
Hello.
Right, so the goal of this Equity Forum is to bring awareness on the different healthcare disparities, especially among Filipinos. And bet you diabetes, cardiovascular conditions is one of the leading morbidities among the Filipino-American communities. So without further ado, I would like to introduce Catherine to present to you our renowned speakers for this afternoon. Kathy, please take it away.
All right, thank you. Hello, everyone. As Dr. Remigio said, my name is Catherine Peller, President of the Philippine Nurses Association of Virginia and the Eastern Region Circle of Presidents Regional Representative. I'm an active bedside nurse in oncology and moonlight as a professor at Old Dominion University and South University. It is my pleasure to be one of your moderators today. It is also my honor to present to you our speaker for today's program, Dr. Jasmine D. Gonzalvo, PharmD, and Chris and Teresa Demos, Director of the Center for Health Equity and Innovation. She's also a clinical professor in the College of Pharmacy at Purdue University. She provides cardiovascular risk reduction medication management services for diabetes, hypertension, dyslipidemia, and tobacco use disorders at Escanzi Health Picar Health Center for a largely Latinx Hispanic population in a federally qualified health center. She has served on and chaired national boards for diabetes organizations. She is active in advocacy efforts at the state and federal levels, most recently having served on the National Clinical Care Commission, charged with making recommendations to improve diabetes across federal programs. Her research interests relate to community health workers, cardiovascular risk reduction in disinvested populations, integration of the Spanish language into practice and academic settings, and diabetes self-management education and support in the pharmacy setting. She has received a variety of awards highlighting her excellence in practice and teaching throughout her career. Please welcome Dr. Jasmine Gonzalvo.
Thank you for that introduction. I am happy to be here. Let me go ahead and share my slides. Okay. And can somebody give me a thumbs up that you can see my slides, please? Perfect. Okay. First, we're going to start off with, let me see if I can advance my slides here. Well, you can see them, but I can't advance them for some reason. One sec. I'll try this a different way. There we go. Okay, so maybe I can't see everybody, but how many people here have prediabetes, diabetes, hypertension, or high cholesterol, if you don't mind sharing. If you could just maybe raise your hand or turn on your camera. There's a raise hand function. Okay. I see some actual hands. Yep. Okay. That's from the ones I can see, there's maybe at least a quarter of us, maybe a third of us. I have prediabetes. Okay. Okay, so that makes the conversation very relevant in a lot of ways. I also think that we, a lot of us, from what I can see, or from what I can maybe assume from a lot of our names, are also racial or ethnic minorities as well. So a lot of this information can be very relevant to us today. So like I said, maybe a quarter to a third of us on the call today do have some of these conditions that I'll be talking about. Okay, so the objectives today of the presentation are first to just identify common barriers and disparities in diabetes and cardiovascular conditions. So for some of you who may not be familiar with sort of the cardiovascular terms and definitions, it's really high blood pressure, high cholesterol, and a lot of that kind of coming packaged together that raise your risk for having a heart attack or a stroke. So that's really what we're going to be talking about today. And usually all of those, or a lot of those, go hand in hand. For those of you who are nurses or in the healthcare profession, we're going to talk about the role of nurses in being able to improve access for under-resourced populations, and we'll also propose solutions, particularly for nurses or as relevant to nurses, to help mitigate disparities and overcome access barriers. I want to spend a little bit of time first talking about this picture, and there's a lot in this picture, but what I really want to start with first is sort of the bottom left-hand corner, where you see, okay, if people and communities are being raised in conditions where there's pollution, there's poor quality schools, so education isn't great. There's institutional racism and discrimination, poor access to employment opportunities. If that's where sort of the environment starts, that will manifest later on down the road at the sort of the top of the tree there, where you see malnutrition, depression, obesity, stress, heart disease, cardiovascular disease, worsened cardiovascular outcomes, because sort of the earlier phases in life and the earlier exposure in life presented sort of the right baseline and sort of the right conditions to manifest later as poor health outcomes and poor just state in general. If you look at the right-hand side of the picture, where you see inequities low and community assets are high, then that's when you see better health outcomes. So for those who are early in life, are exposed to good access to health insurance, quality housing, access to healthcare, access to healthy, nutritious foods, good education, that will manifest later in life in better outcomes with, for example, infant mortality, nutrition, and mental health outcomes, and relevant to the discussion today, heart disease. So this is, I doubt this is something new to any of you on the call today, but it's also just been, especially over the last 5 to 10 years, a lot more people are starting to pay attention to how a lot of these factors sort of at the root of the trees are really having an impact on health outcomes. And we as healthcare providers need to be paying a lot more attention to the things at the roots, rather than waiting for what I call, when people get to interface with the health system, with nurses, with pharmacists, with physicians, with the health system, we're putting out fires, so to speak, right? So for example, I'm in the outpatient setting and I'm in primary care. And a lot of the patients who get referred to me have A1Cs of 10 or greater. I call that putting out a fire. We're basically trying to keep that person out of the hospital, improve their outcomes, but they've already come to me with sort of a bad situation or kind of a difficult situation. A lot of perhaps the sugars, the blood pressure, the sugars are already, it's been high potentially for years. And a lot of the sort of physiological damage has already been done by the time they even get to me. So I consider that putting out a fire. And systemically, as a health system, we have to think about, well, what are these factors at the roots, so to speak, if you reference back to the picture, what are those things that we can influence so that when the person gets to us, we're not putting out a fire, but that we're having wellness conversations and we're saying prevention conversations. And I think it's really been only in the recent past that there's been much more attention paid to prevention, wellness, social determinants of health. And I think that we need to collectively be paying more attention to those factors to be essentially moving the needle in the direction of healthier communities and mitigating health disparities. I hadn't used these terms in what I was previously discussing, but when we talk about upstream factors, so we kind of look backwards when we think of upstream factors, right? So how did factors related to income or discrimination or a lot of the social determinants of health, low educational status and opportunity, how did those upstream factors then influence sort of the idea that we're going to put out someone's fire, right? So those are the upstream factors. There's midstream factors as well, social needs, homelessness, nutrition insecurity, and trauma that can come in between sort of those upstream factors. And then the downstream factors really being what I was referring to as putting out the fire of disease treatment and chronic disease management. When we've already gotten to that place of diagnosis or needing to treat or manage the condition, we're already there, right? So that's one way to look at the sort of the continuum of getting to the roots to the leaves of the tree, so to speak, or the branches, the bare branches, depending on what the upstream factors are. So this terminology has again become more common recently, saying, okay, what are those upstream factors that we do have a role in improving, or that we should be paying more attention to, or that we actually need to be doing more screening towards, right? So I'll talk about that during sort of the last third of the presentation. Of screening is a really good place for healthcare providers, nurses, pharmacists to be doing some assessment of the upstream factors. We can't always be radically changing discrimination, but we can be doing screening and assessment for those with our patients. This is another way to sort of characterize by way of a model, a social ecological model that looks at the multi-layered barriers that disadvantaged communities may face. So so if we start at that purple level, individual knowledge, beliefs, preferences, and skills. So that's just the individual, that's sort of self-explanatory. Then you can branch out to interpersonal, the relationships and family networks, interactions with the healthcare providers, health systems. Then you look at the community and local organizations, neighborhood and characteristics, all the way to societal, policy, national or state laws and regulations. And when we're thinking about health disparities, you can start to name barriers at each one of these levels. And the more barriers that you have at each one of these levels, the worse outcomes that you can see, right? So what are for example, so what local laws may be in place that contribute to continued systemic health disparities? And some of that may even go to, for example, voter redistricting, right? And how does redistricting sort of allow for communities to be continued to be discriminated against or marginalized because of that voter redistricting? That's just one example of how perhaps a societal or policy regulation may actually filter down to impact somebody's health. And so there are barriers at each of these layers, and the social ecological model can just sort of present it in a way where you can break it down into where may one community's biggest barriers be, or where are those community members coming across the biggest barriers. I always like to talk about the social vulnerability index of communities as well, because it's another thing that perhaps a lot of people haven't heard of or been introduced to. And it's really a quantifiable, it's a number, it's a measure that we can objectively look at when we look at communities. And so when you're looking at this map, the darkest blue is actually where there's the highest social vulnerability index. The components that go into calculating the social vulnerability index are things like poverty, lack of access to transportation, crowded housing, human disasters, disease outbreaks. So when looking at this map, and I don't know where everybody's from here, but if you live in one of those areas, you may be in an area of a high social vulnerability index. And all of those combined can contribute to negative health outcomes and health disparities as well. When we look at how we can impact or reduce the social vulnerability, we can also decrease human suffering, economic loss, and potentially mitigate health disparities. So I think that this is a really nice way if somebody's looking for, again, sort of a quantifiable or objective measure of the sort of the state or economic disadvantage of a particular community, that this is one way to reference that, again, in a quantifiable way. If we look at diabetes in particular, and diabetes gets a lot of press because of how prevalent it is, we can see that there are a lot of people by race and ethnicity, by education level, and by family income level that we can see people diagnosed with diabetes in these spaces. And we know that the diagnosis and prevalence of diabetes skews towards racial and ethnic minorities, as well as those who are lower socioeconomic status as well. And we have numbers to prove that. We also look at things like health literacy for diabetes outcomes. So just to orient you really quickly to these two charts. So A1C, some of you I'll just level set here. Some of you may not be familiar with A1C, and A1C is the number that tells us what your average blood sugars were the 3 months before, right? So typically we for most people with diagnosed with diabetes, an A1C of less than 7 is desirable or is considered healthy. And an A1C of 7 is about a blood sugar of about 154. And so when we look at those with adequate health literacy versus inadequate health literacy, we see that the outcomes or the A1C levels are better for those with adequate health literacy. So some of the factors in health literacy is just being able to understand sort of the terminology and the language that's used in conversation with healthcare providers or in a visit with a healthcare provider. But that also extends to, especially when you're talking about something like diabetes, you're also talking about nutrition labels, reading nutrition labels. And we might be talking about health literacy or health numeracy here, where it's complicated to read a nutrition label. And when we're talking about diabetes and having to read portion sizes and grams of carbohydrate and grams of added sugar, grams of fiber, and doing a calculation, it's really easy to see how, if that was the expectation of somebody to help manage their sugars, that it would be difficult if you have limited health literacy. So what we know that these disparities exist. And again, if you go back to that graphic that I started with, where if you have exposure to inadequate or insufficient quality education, that again, that manifests as differences in health outcomes. So this is just another aspect of that, particularly as related to diabetes specifically. When we extend out to hypertension or high blood pressure, we know that hypertension affects almost half of the US adults and contributes to cardiovascular disease burden. We also know that it's disproportionate, that it's higher among non-Hispanic Black adults versus non-Hispanic white adults, and may develop at younger ages as well. And we know that if it develops at younger ages, then that's a higher lifetime cumulative exposure, in which case, again, cardiovascular outcomes will be worse. The negative impacts of racism on cardiovascular health. We know that Black adults experience a higher burden of cardiovascular risk factors, particularly as with regard to blood pressure and obesity, and they're more than twice as likely to die of cardiovascular disease relative to white adults. We also know that in American Indian individuals, 1.5 times is likely to be diagnosed with coronary heart disease compared with the white population. And there's increasing evidence, and this is from a publication just from 2022, that there's increasing evidence that points to structural racism as the root cause of racial and ethnic disparities in the United States. And that could be a presentation in and of itself of how to unpack the different factors that contribute to structural racism. One of the things that I really want to highlight here as well is barriers to accessing or using technology. I'm sure that all of you can know that technology, the speed at which technology advances is difficult to keep up with. And as particularly for diabetes, but also some other cardiovascular conditions, there are device updates that are difficult to keep up with. And for me, as someone who specializes in diabetes as well, and cardiovascular conditions, even just trying for myself to keep up with the different changes, let alone teach it to other people, let alone teach it to people with a number of barriers to perhaps learning or comprehending, utilizing, accessing. We then have, again, multifactorial barriers to improving health outcomes. This may be related to physical disabilities. We already mentioned health literacy and numeracy, limited digital literacy. So there's a lot of different types of literacy that people can experience: declining cognitive function and memory loss, no smartphone access, concerns with having a device attached to their body if we're talking about something like an insulin pump, for example, or for a continuous glucose monitor. So for some of you who may not be familiar with a continuous glucose monitor, a CGM, it's the one you've probably seen commercials where people will scan their phone on their little sensor attached to their body. It might be on their abdomen or their arm, where they're not having to do finger stick blood sugar checks, but they can see their sugars as every 5 minutes without having to stick their fingers. So that's a continuous glucose monitor. History of site integrity issues in case they're unable to tolerate something being attached, or perhaps a negative experience with a previous trial of technology. All of these can contribute to, again, disparities for those communities and those individuals who have really good insurance and they have no barriers to obtaining certain technology. You can see how advances in technology and access to those technologies can help people improve their health, and those who don't have access to the technology can lag behind. And you can see this in happening as we speak. And so, for example, I'll use an example of the continuous glucose monitor. Someone who can see their blood sugars updated every 5 minutes and is motivated to change the way that they're eating because they know that rice or pandesal, for example, can increase their blood sugars significantly, and then they only eat perhaps half a pandesal or switch to whole wheat pandesal, for example, they can see the difference even from one day to the next by being on their CGM, right? Whereas if somebody was doing finger stick monitoring and just checking their blood sugar, before they eat pandesal, and they say, oh, before I eat my pandesal, my blood sugar is 100. Then I eat my pandesal and my rice and my longanisa or whatever. I'm just contextualizing it here for the audience, but maybe after you eat, you don't check. And you don't check your blood sugar, and and what actually is happening is that after you eat half a pandesal, longanisa, and rice, that then your blood sugar goes up to 300. But you only checked your blood sugar before you ate, and it was 100. And you feel good about yourself, and you feel good that my blood sugars are doing great. That can, again, the limited access to technology, or even there are other barriers here that we can also touch on. If your doctor or provider is not familiar with the CGM device and has not mentioned it to you, or if your insurance doesn't cover it, there are a lot of barriers to individuals not accessing a CGM for whatever reason. And you can see, like I said, that real world example of someone who's just getting one instance of what their blood sugar is versus knowing what their sugar is every 5 minutes. Right. So I'd be remiss in if I didn't mention barriers to technology here. Some of these other interpersonal barriers when you're talking about technology in particular are also listed here. Implicit bias, I think, is one where you really have to be careful in health systems that, especially, for example, myself, what if I think someone can't use a device? Does that mean that I don't offer it to them because I think someone can't use the device? What if it was instead health system policy to recommend X device to every patient with high blood pressure, for example? If there was a device that made people's blood pressure better, it would be good health system policy to recommend that device to every single person. And so that's when there are multifactorial barriers that if there aren't policies in place, that those things can happen, that there maybe that provider is not racist and that person, it's just implicit bias sometimes can influence what is recommended to different patients. And again, in this idea of implicit bias, it doesn't infer that somebody is racist or has any negative intentions. It's just that maybe that sort of passive lack of awareness of just saying everybody should have access to this, and it's not my decision as the provider to decide whether this person should be educated on this. It's up to the patient to decide, and up to the insurance company, unfortunately, whether or not they would cover it. But also lack of social or capital support, limited cultural humility, limited access to self-management data. Therapeutic inertia is another thing that we see here. And again, would be sort of on the healthcare provider side. What we see with therapeutic inertia is when, for whatever reason, treatment is not advanced. So let's say you go to your primary care provider and you have high blood pressure, but it's just a little high. Let's say it's just 148/96. That's just a little high, right? And so maybe you as the patient say, well, it's just a little high, so I'm not going to do anything. And the doctor says, okay, let's just bring you back in a month and we'll recheck it. And then maybe it's just a little high again. Maybe it's 142/92 this time. And then again, it's sort of like the idea of kicking the can down the road, right? That's also therapeutic inertia, because we're just prolonging the exposure to high blood pressure in this example that I'm using, right? When really, perhaps when the person is outside of clinic, the blood pressure could be jumping up. We don't know what it is. So it really is months and months and years sometimes that people can go with negative cardiovascular outcomes, negative diabetes outcomes, because of this idea of therapeutic inertia. And one of the things that I typically recommend for patients and for anyone involved in this conversation is that to be a patient advocate, to advocate for yourself. So for example, if you know your blood pressure is high, say, I'd really like to do something about this because I know that it's important to have my blood pressure at a safe level, right? Therapeutic inertia can be both on the provider side as well as the patient side. In terms of, on the patient side, I don't want to increase my medicines. I don't want to add more stuff. And all of that can contribute to therapeutic inertia. But the longer that somebody has uncontrolled high blood pressure, the longer that somebody has high blood sugars, the worse outcomes or the worse pathophysiological damage that can occur as well. So that's one piece that I really wanted to pull out here is the therapeutic inertia piece. We can also see community barriers. So I'm really sort of going along that socio-ecological model that I presented in the beginning as well. So community barriers, There are communities that have lack of adequate healthcare. So particularly, we may point to rural communities, right? Farming communities where you have to drive really far and it's not convenient to access healthcare. There may be clinic or health system protocols that limit access to technology. There may be limited broadband access, as well as the social determinants of health, which we talked about a little bit earlier in terms of those things that contribute to employment, education, and whatnot. Those are some of the community barriers. And societal or policy barriers. The map I have here, again, relates to the continuous glucose monitor as an example. So what we see here are the light blue, and this is for Medicaid. So for Medicaid populations, where access to continuous glucose monitors are covered. So the darker colors are CGM is covered for people with type 1 and type 2 diabetes. The lighter blue states are just for people with type 1 diabetes, for example. So this is an example of, again, it's highlighting that it's not equitable across the United States of who might have access to, in this example, better advanced technology. Okay, and I hope I'm going to field all of the questions at the end. I think we're going to have plenty of time to ask questions. So please keep putting questions in the chat, or you can save them towards the end and verbalize them as well. And moving on to the second one here, and in terms of describing the role of nurses in improved access for under-resourced populations. This is a really long quote that I can't actually see the whole thing because I have some other things on my screen, but just read it here. I'll be quiet for like 5 to 10 seconds and you can read it because I really liked it. And for those of you who are nurses in the audience, this is really just sort of a statement that really advocates for nurses playing a significant role and choosing to play a significant role in this health equity landscape. And it can be in a variety of different sectors. It goes back to the code of ethics for nurses, and I'll paraphrase here or highlight one or a couple of pieces where it's basically saying that doing work in the social determinants of health is an expectation in the code of ethics for nurses. All nurses through organizations should be involved in nurse formation, education, development, must firmly anchor students in their responsibility to address unjust systems and structures, modeling the profession's commitment to social justice and health through content, clinical and field experiences, and critical thought. So again, just sort of the nurse's duty to do that, as particularly related to education as well, and the next generation of nurses. I want to pause here and hopefully people will feel brave to discuss and chat, but I think this is really interesting. I have some that are specifically related to sort of the Filipino community and feel free to answer on any of these questions, but I'm curious because I'm not familiar with what's the landscape of health disparities in the Philippines as it compares to, the United States, or how are the strategies related to mitigating health disparities in the Philippines different from the United States? And then some of the other questions here are just, if you're a nurse or if you're a provider or if you are employed by a health system, what do you know is being done at your health institution or workplace that improves or worsens health disparities, or something that you have done to mitigate health disparities, or somebody that has done, or if you yourself has experienced some sort of health disparity. I'd welcome that discussion too. And I'm just going to stop sharing. Well, no, I'll leave these up, but I might need help in terms of seeing people raise their hand, or just, nope, I'm pulling you up now. So speak and feel free to address any of the questions on the screen.
Dr. Gonzalvo, I can start.
Sure.
So-
Orly.
Yeah, it's not a policy, but it's more of an initiative. One of the things that we've started in my organization, just to address the issues of access, especially with those indigenous members of the community, right? Who are maybe way too far from accessing health centers. So what we've done is that we have what you call the neighborhood help. So there are some mobile clinic vans that goes to those areas to be able to provide different health services to those communities. So I think that's a great initiative because it's bringing healthcare services where there is nothing available.
Perfect. So you have, particularly at your institution, you have a very dedicated and deliberate effort for the indigenous populations to make sure that there's a specific lens on the care for that community.
Yes, yes.
That's
Mhm.
awesome. Anyone else like to share? Okay, I can go on. Okay, let me just minimize my screen here.
I just had a question, Jasmine.
Mm-hmm.
How do you motivate people who have diabetes, are on metformin, and are just not sticking to their diets because they feel they're already taking their medications?
I think that's less about the healthcare provider and it's more about the person. I think personally, I do, when I'm communicating with people, I say, well, you tell me where you would like to see your sugars. If we know that your A1C is tells us that if it's 9 or above, that your sugars are in the 200s, 300s sometimes. And we know that your sugars, or what happens when your sugars are in the 200s and 300s, is that it does damage to your eyes and your kidneys and your nerves. Then if you're comfortable with that, then one option is that we can leave everything the same. It's your choice. If your sugars are closer to that 150 level the most of the time, and we know that that's a healthy level where it's not doing damage to your eyes, your kidneys, and your nerves, and it's not increasing your cardiovascular risk, then you have 3 options to improve your sugars. And it's typically physical activity, medications, or dietary choices. Which one of those sounds easiest to you that you can make a change right now if you'd like to improve your sugars? That's how I communicate with my patients, because it really puts the ball in their hands to make the change. It's not about me. It's not about me as a healthcare provider telling you what to do and what you're supposed to do. If you're happy with, or if you're comfortable with your sugars in the 200s and 300s, knowing it's my job to provide the education, right? So if I provide my education and say, if your sugars are in the 200s and 300s, this is what's happening to your body. When your sugars are that high, we know that it's problematic and it's doing damage. And when I frame things in that way, saying it's totally your choice to let your sugars continue in the 200s and 300s, then that's your choice. And it's what my job is to tell you what happens when your sugars are in the 200s and 300s. And then it's my job to provide a prescription for you, for example, when you are more comfortable with advancing your medicines, adding your medicines, changing your medicines, adding a continuous glucose monitor. So I wish more providers would speak in those terms with people, because people have the autonomy to take care of themselves or not to take care of themselves. And That's the way that I look at it, that it's really up to people. And, a lot of people will also say, like I said, a lot of people come to me and their sugars are in the 200s and 300s. And their primary care provider said, this person doesn't want to do insulin. And so when they get to me, I say, well, that's okay. If you don't want to do insulin, my job is to tell you what happens when your sugars are this high. And then you make the decision if you want to continue your sugars that high. And then I answer questions about all of the different medication options that can help somebody improve their sugars to a healthier level. So it's not my job to motivate people. It's my job to educate people. And people, if they want to be motivated to take care of themselves and to prevent the problems that will happen if sugars are high, for example, then that's on them, right? So I think that is a way to reframe things. I think a lot of providers will communicate in a way that it's sort of, well, you need to do this, and this is what you're supposed to do, and I'm going to give you a prescription. Bye. When really it's more of a discussion on what would you like to do to take care of yourself, to improve how you feel, to improve your outcomes, to prevent problems later on down the road.
Dr. Gonzalvo.
Mm-hmm.
Yeah, we have a comment here on the chat from Nathalie Zacharias. She said, I moved here when I was a child, but in the Philippines, it almost seems like having a chronic disease is a life sentence. There seems to be even less accessibility to healthcare there than here.
Oh, gosh, that's sad to me. I think maybe it's not surprising to me, but that is sad to hear that it's a, like a life sentence, and that I wonder if that's a common sentiment, if anybody else can sort of comment on that.
I know that we have a lot of challenges in the Philippines when it comes to resources. And thanks for showing that socioeconomic vulnerability index. I know a lot of the places in the Philippines doesn't have access to those primary screenings, and majority doesn't have those monitoring gadgets, right? Their blood glucose monitor. So I think we have a lot of things to work on when it comes to trying to advocate and work on our legislative bodies in terms of advocating for those services.
Thanks, Marley.
Mm-hmm. I think there's another question on the chat, Carol, right? From Janet.
Yeah, I was going to wait until the end. But but I could ask now since you have asked. From Janet, she asked, are you an advocate for intermittent fasting?
I'm yes and no. I think I'll say why no. I think it's really difficult for people to maintain it. I think that people really like the outcomes and how sort of quickly you can see weight loss in particular, improvements across a number of different cardiovascular conditions too, diabetes and blood pressure. I just think that it's really pretty restrictive. And so what I've seen I've seen people be successful with it, but then sort of not be able to stick with it after maybe several months. So I don't necessarily advocate for one thing versus another. But if it works for somebody, I think it can be good.
Thank you, Dr. Gonzalvo. Just wanted to share, not really related to diabetes, but our chapter, the PNAA of Metro DC, had built a health hub, and it was just recently turned over to the indigenous people we call them ITAs in Zambales. So with that, we are hoping that, it will be it will be a source of a health equity start for them. We are staffing it with a midwife and a physical therapist and a doctor's visit, probably like a quarterly basis. So that's our contribution to the promotion of health equity.
I appreciate that, Carol. Thanks. Okay. I think I'll move on to just the last few slides since we have about 13 minutes left, and I want to make sure we have a little bit of time for questions, but I'm glad we were able to field some now. Okay, so what are some of the solutions? It's not all bleak. There are some solutions that we know that can help mitigate disparities and overcome access barriers. So areas of activity that strengthen integration of social care into healthcare. So social care really just being sort of those, a lot of maybe the upstream factors that we talked about earlier in the presentation that contribute to the downstream factors that the health system has more traditionally been interfacing with. So we look at this little diagram, and the things that we can do are for awareness. Ask people about their access to transportation is an example, right? So if we don't know that somebody takes the bus, for example, to get to a clinic appointment, and we, let's say the bus was late and then they get to their appointment late and now they can't be seen because they're late. And so they have to be rescheduled. How frustrating that would be. That would be incredibly frustrating. So if we do a proactive job about asking people about their access to transportation and how we may have to accommodate based off of limited access to transportation, that is potentially something that we could do in terms of access. And then activities focused on individuals and adjustment, reducing the need for in-person healthcare appointments by using other options such as telehealth appointments. And that became much better during the pandemic with telehealth and reimbursement available for telehealth, but some of that has gone away or is going away. So we have some work to do in terms of the infrastructure of allowing for telehealth appointments or telephone appointments that could help improve health disparities as well. Then when we look at the assistance for individuals, we say provide transportation vouchers so that patients can travel to healthcare appointments, and vouchers can be used for ride sharing services or public transit. So that's another opportunity that a health system could potentially consider. Then when we look at the community, sort of the bottom half of the chart, and we look at alignment, we say invest in community ride sharing or time bank programs. So activities focused on communities, you may also invite community partners to the table. So what other community partners or community organizations may have some of this infrastructure in place that you can partner with as a health system? And then advocacy, we've also talked about basically just policy at a very high level to advocate for, again, sort of in this example, transportation access. So nurses can also conduct screenings in the 5 key domains of social needs. So that's just the social determinants of health, education, employment. So screenings to assess what people's individual barriers may be in that area, and perhaps obviously reviewing their results and care plans based on social needs as indicated by those results. Refer patients to appropriate professionals in social services. That may be care managers, it may be social workers, it may be mental health professionals, it may be pharmacists, it might be community health workers, it might be other community-based organizations. And coordinating that care amongst all of those people is obviously a team effort, and making sure that nobody falls through the cracks, just by making the referral that you've done your job, but that there's some structure in place to make sure that there's follow-up and that those things actually happen. So for example, at our clinic where I practice, there are the case conferences where people with really high, particularly social needs as well, where we do have a lot of the team members involved, that there is dedicated time to say, okay, what happened with that referral? Was that person connected to care in these different ways? And all of this has to be supported by employer policies, right? So even if you, as a nurse, for example, are not or you want to do these things. If you're not supported by your employer to do those things, then you're not going to be successful at doing those things long term. So being an advocate for the policy change probably would be your first step before also doing some of these, or maybe you could do them simultaneously. Again, looking at these factors, we can look at, the easy place to start, because it's our bread and butter, so to speak, is the downstream factors, the clinical care. That's what is already part of what we're doing as healthcare providers, is the clinical care in the downstream factors, disease treatment, disease management. With the midstream factors, it's those screenings. So screening for housing insecurity, nutrition insecurity, that's where there may be opportunities, even, immediately, if you feel so compelled, that you could start looking into incorporating screenings, or even at minimum, identifying where those screenings are occurring, so that you can, as an individual provider, can be aware of, I know that those screenings occur at this place with this person, and I know that person maybe has access to that information. And some of these upstream factors, I think, I put a question mark here, but is where we're doing a lot of the work now, in terms of how do we influence low education as healthcare providers? What are those things? And I think a lot of those things really just take us, for example, all of you are here on a Saturday listening and learning about some of these models and some of the opportunities to help. So I think that we as healthcare providers, or as nurses, or even as citizens, as individuals, learning about these things is a first step in improving some of the upstream factors within your own communities, within your own social circles, and just recognizing that a lot of the disparities exist, and giving respect to that they exist, and obviously not worsening them in any way. So there's a lot of work to be done in that space. Advocating for change. So contributing a health perspective to public policies and decision-making. So literally you can go to the State House and testify in health committee readings, if you're familiar with identifying a bill and testifying on behalf of that bill, serving in public and private sector leadership positions, and using your expertise to promote policy changes that support health equity, regardless of where you are. So making sure that the policy changes don't leave certain groups behind, or exclude people that perhaps may not access. And I think one of the most notable sort of areas that you need to pay attention to are those policies that relate to technology, like I said. So can somebody do our insurance policies not covering technology, the most advanced technology, the most up-to-date technology? So again, that technology is a big piece of where disparities can happen. So sort of in conclusion, advancing health equity takes support for the willingness of the nursing workforce to take on new roles and new settings in the community, or advocating sort of that employer support that I just mentioned. Being prepared for the whole stream, so upstream, midstream, downstream, and playing a role in, or at least advocating for patients in each of those spaces. Learning, experiential learning, so having nurses doing public health work or in communities, and you don't even have to be a public health nurse, but a nurse who has the opportunity to work in a community or engage with community-based organizations is another way to expand in that direction. Nursing education that goes beyond just the principles of diversity, equity, and inclusion, but providing sustained student engagement in hands-on community and clinical experiences with these issues. So as much as you sort of interact with students and learners, having them pay attention to some of these inequities and get experience is also paving the way for the next generation. Funding to support new models of care. So if any, again, particularly public health nurses may be writing grants or exploring grant opportunities to fund equity initiatives, deliberate equity initiatives, or even administrative nurses. Evaluation of models to build the evidence needed to scale programs that really have been proven to mitigate health disparities would be critical as well. So, this is kind of a tough question, so I think we can roll it into perhaps any other questions, knowing that we have about 4 minutes left. But I don't know the answer to this question, so I just kind of want to open it up to discussion in case, so when community resources are limited and you say, okay, I'd love to refer this person to a housing insecurity organization, but that doesn't really exist, then what do you do? So like I said, I'm going to roll this question into any other questions that you all may have, but that was the end of my content. I'll stop sharing there. And Carol, I think maybe you'll field any questions or share any questions with me that have come up.
Yes. Hi, Dr. Gonzalvo. So there's a comment on the chat. It says telehealth and home visits are reimbursable services and are here to stay.
I hope so. And I think it may sometimes depend on which part of the country you're in. I'm in Indiana, and we've had some disturbances in that space, and so it's been difficult. But so I hope that continues to be the case in the majority of states.
You mentioned about some services stopping because of, I guess, the May 11, the public health emergency will cease. Can you give us some services that will be affected by this?
So the one I know of at our institution in particular was the idea of how it was more of a limiting of the telehealth services. It was what was previously reimbursed in the height of the pandemic was telephonic, and it can just be telephone based, and that would be reimbursed for providers interacting that way with patients. It then switched that it had to have a video capability component. And that was really difficult for a lot of our patient population. And for a while there, our health system was just eating the costs of telephone visits that didn't have the video capabilities as well. I think we're sort of coming out of that in terms of finding creative ways to make sure, like we incorporated community health workers who have access to tablets, who would like literally go to someone's house and have the video tablet in front of them to sort of get, it was sort of a workaround, right? So that was an example at my health system here.
Thank you. Any other questions from the participants?
Dr. Gonzalvo, I just want to ask your perspective on how we can change some of the mindsets that our fellow Filipino fellows back home. I know they usually wait before they consult the doctors, right? When they started having some symptoms, we know that diabetes is a chronic illness. So how can we be more proactive and probably engage them early on for some strategies to promote their health and prevent some of these chronic illnesses?
Yeah, Worley, it's a fantastic question. I wish I had a good answer for you. I think the best answer I have is really just communicating in the way that I know how and that I would suggest to other people, is saying, this is your health and it's in your own hands. And when we make choices that, and I'm not saying it's easy. It's not easy to make healthy choices consistently. It's easier to make unhealthy choices sometimes, but it's also protecting ourselves. It's protecting ourselves for our loved ones. It's protecting ourselves for our kids and our grandkids. And that motivation has to come from within to really take care of yourself, to really be motivated to take care of yourself. And so this idea of sort of ignoring a health problem, you only stand to hurt yourself by doing that. And so I think as much as we can get that message out that no one else is taking care of you besides yourself, in some cases, some other cases people are taking care of you, but I think that motivation really has to be inspired from within.
Thank you, Dr. Gonzalvo. And with that, our time is up. So, Warley.
Yeah, so this is really a great presentation. And again, we would like to thank Dr. Gonzalvo for gracing her time. And I'll be remiss if I don't recognize Tita Teresa. She's here too. Say a wave. Tita Teresa is the president-elect of PNAA Virginia, and the mom of Dr. Gonzalvo. So I really appreciate your support. And I see Janet as well, the president of PNAA New York, who joined us. So this is the first of the many webinars that's coming up. Again, in our commitment to address healthcare disparities, especially among the Filipino American communities, I hope that the webinar today sparked some inspiration. I know I have a lot of takeaways. Thank you so much, Dr. Gonzalvo, for amplifying the role of nurses in terms of closing some of these disparities, because I know that we can do a lot, right? As Carol mentioned, there are a lot of great initiatives that PNAA and some of the chapters have been already initiated. The Health Hub with the ADAS community. I know a lot of us just came back for medical missions in the Philippines, trying to bring the awareness that if we work together, right, not only in education, not only in leveraging practice, but also the work for advocacy, we will be able to address some of these challenges that we're seeing today. So with
Thank you for having me.
Thank you so much. Thank you, Kat. And we want to thank our participants for gracing their Saturday with us. See you to our next webinar, March 24. And that is about tuberculosis among Filipino Americans. Thank you and have a blessed weekend.
Thank you.
Okay, so we're gonna take a screenshot. So if we can have your videos on, please. All those who are not shy.